Hello, everyone, and welcome to today's ACR Foundation Health Policy Research 101 webinar. Before we get started, I would like to go over a few items so you know how to participate in today's event. When you join today's webinar, you selected to join either by phone call or computer audio. If for any reason you'd like to change your selection, you can do so by accessing your audio pane in your control panel. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation. The presentation is available for download in the handout pane of your control panel. You may download this presentation anytime. I would now like to introduce Dr. Danny Hughes, the Executive Director of the Harvey L. Newman Health Policy Institute.
Thank you, and good afternoon. Today we're going to talk about translating research to evidence-based health policy for the radiology community. But the first question you might ask is, what is policy exactly? Traditionally, people think of this as being something that occurs on the Hill. Legislators, congressmen, passing laws, cutting deals, and making important decisions that will influence the lives of ordinary Americans like ourselves. But policy is actually much more than just that. It also occurs with federal regulators, CMS, Health and Human Services, other large organizations such as the Veterans Administration, through their rulemaking processes and the regulations that they pass. But policy also occurs in another important venue that's often overlooked by folks in the policy arena, and that would be private organizations. Organizations such as payers, meaning other healthcare insurers, large hospital networks and systems, and other organizations that pass various rules and policies regarding either payments, reimbursements, coverage decisions that are very important to the radiology community. So ultimately, when you're talking about the policymaking process and where research occurs to inform that process, you really have to think of all of these different groups of stakeholders to have a full grasp of how this interacts and interplays in ways that radically influences the way that radiologists practice medicine. So what changes policy? I know the thing everyone's thinking of at the top of their head, money. Big stacks of $100 bills slid in briefcases and back alleys and parking lots, and hopefully on the other side comes policy conclusions they're very happy with or not. But the problem is, everyone's got stacks of $100 bills. The folks with policies adverse to yours. And quite frankly, that is not enough to make the difference. So what does? What do these dollars do? Well, quite frankly, what money buys you is legislative access. It's going to open the door. It's really just a key to an office door that provides you access to make your case, present your evidence, and hopefully change policy in a way that's going to be beneficial for your constituency. But the key questions are, what happens after that door is open? And what about non-legislative policy? Because as I mentioned, a lot of policy occurs outside of the legislative process. So again, it's going to be much more than simply pure dollars and money. So what else? Well, advocacy. What I like to think of as the policy sales team. You'll find here ACR's very excellent government relations group who performs very important activities. They develop relationships with legislators. They develop relationships with congressional staff so that their perspectives on policy issues are actually listened to and heard. They monitor and track relevant legislation to make sure they're fully abreast of the changes that could come down the pipe and change policy for the better or the worse. But most importantly, what they're fundamentally doing, because know what I call them, the policy sales team, is they're selling ideas. Ideas for how to change policy for the better. Now, of course, that's just on the legislative side, and I just mentioned there's so much more to policy than that. What about the non-legislative policy? Well, they're going to follow the federal rulemaking process. For example, CMS every summer drops their proposed rule for changes regarding quality, payments, reimbursements for the subsequent year. And when that proposed rule is dropped, this legislative team The economics team and other folks at ACR are going to read every word of that 500-page, 1,000-page, 2,000-page document and look for the key clauses that are going to be relevant to radiology. At that time, they'll have an opportunity to submit comments to these proposed rules in terms of what they think makes sense and provide evidence that might be relevant. Or in other words, they're selling ideas. Ideas for how to change policy for the better. So just as a recap, RADPAC is a key that's going to open the door. It's going to provide that access so that advocacy can walk inside and sell these key ideas. But where are these ideas coming from? What are they selling? What is this portfolio in her hand that we've just circled? What is this? Let me tell you. It's research. So just to channel Ed Deming, the management guru, through the dude, without data, quite frankly, it's just your opinion. And we're going to see that in a couple of examples further on inside this webinar. So ultimately, you've got to have quality research. But it's not just having research, not just having data. To be meaningful, effective research simply must be credible, objective, and reproducible. If you're simply seen as a shill for what's great for your constituency, it will be ignored every time. And so you absolutely have to have a very long arm's length relationship from the sales team, from the dollars. It has to be seen as truly objective. The wonderful thing is ACR's leadership thought about this and recognized the importance of having real, credible, evidence-based research. So in 2012, they established the Harvey L. Newman Health Policy Institute to study the role and value of both radiology and radiologists in a wide variety of issues that are relevant to you today. Things such as emerging care delivery models, alternative payment systems, and really thinking about where you fit in as the healthcare payment system transitions from volume to value-based care. And it's also key to fundamentally understand the impact of imaging on overall healthcare costs and quality, because first and foremost are our patients, and making sure we have the right regulations in place to ensure that we can maximize patient care in a sustainable way for the overall healthcare system. So what do we do at the Newman Institute, you might ask? Well, we really have three key goals. The first one is to produce real science, peer-reviewed research that's going to be placed in scientific journals to inform the debate, credible, objective, really cutting-edge research to inform policy in meaningful ways. A second goal is really to generate actionable data that policymakers and practices can use to inform policy and how they choose to practice medicine. And finally, we support external researchers across the country in academic medical centers, a combination of radiologists and non-radiologists, but not in clinical research, policy-oriented research, examining the effects and possibilities, and thinking to the future about trends that could potentially impact radiology so that evidence is in hand when we most need it. So in the process of doing this, the Newman Institute produces a true continuum of research products that spans what I like to think of as pure analysis and research, all the way to a synthesis into real policy points that could be understood by the various policy stakeholders driving the agenda in those various policy frameworks. What does this continuum look like? Well, it starts with peer-reviewed publications, as I mentioned, and you intentionally want to have a very broad scope. If you simply publish research into the radiology literature, it'll simply be seen as shills for what's good for radiologists. So we work very consciously to place our work into the general healthcare journals, whether it's JAMA, New England Journal, JAMA Internal Medicine, policy journals such as Health Affairs, Medical Care, specialty journals. For example, we've done work examining imaging in emergency departments, but if we want to make a difference, I want emergency department physicians to read it. And so we'll put things in like the American Journal of Emergency Medicine. So again, intentionally broad portfolio of science to inform policy in a meaningful way. As we move a little further towards synthesis, we've got scientific presentations. Any academic researchers on this call knows you can publish a paper, but it doesn't mean anyone's going to read it. So to do that, we have to have that outreach. We have to go into the community and present this to our scientific peers. Beyond that, we move into data products. We've collected an awful lot of data to produce this research, whether it's Medicare data or other publicly available data sets. And we want to take that and synthesize it into web-based tools so that lay users, policymakers, researchers, or private practitioners can truly have access to all of the data they need, understanding imaging utilization, spending, workforce issues, and trends, so that they have that rather than having to perform a dedicated study to learn some very precise statistic. And that's something we provide. Going further, this becomes synthesized, because you'll see the data products are right at the middle of this continuum. Now we have to synthesize it into, well, we have this objective data, but what does it really mean? So we'll do that in policy briefs, white papers, either through HPI or in conjunction with other specialties, and also through outreach. These would be the conversations that we're having at ACR's annual meeting, state chapter meetings, industry and trade press, where we can take this very jargon-heavy scientific research filled with statistics and turn it into language that policymakers and practitioners can understand. Of course, we have to address multiple stakeholders, and all of these products are designed to do exactly that. For example, key stakeholder, radiologists. They want to see what they can do to improve themselves, whether it's understanding how to better compete within MIPS or how to better adapt with other kinds of value-based payment models. They would like access to data to help them manage their practice through our web tools. And of course, through the policy process, we care very much about government legislators and regulators to ensure they have real data that informs real decisions. And you'll see an example about that in just a few minutes. But at the same time, we also do very rigorous, complex modeling and scientific studies that are actually targeted specifically for academics and policy thought leaders, because at the same time that our policy team and our research is doing its best to inform policymakers on the medical imaging policy, there are others out there with their own perspectives. And so to the degree that we can influence the other researchers at other think tanks and other thought leaders at payers, well, then that's going to really leverage what we're doing by having it from multiple sides of the policy perspective. So for the remainder of this webinar, I'd like to spend a little bit of time talking about a couple of very concrete policy initiatives that have been informed by research from the Newman Health Policy Institute, so you can better understand the full range of the policy process and where research plays a strong role. So the first thing I'll talk about is the Multiple Procedure Payment Reduction Act. This comes from the first stakeholder we talked about in policy. This was legislation. It was designed to reduce payments for subsequent same-day, same-patient advanced imaging services. Starts out in 2006 as just a 25% reduction of technical component cost. And while it ultimately was a 50% reduction in technical component and a 25% reduction in professional component in 2011, if you saw the proposed rules, the initial numbers were in the range of 75 to 50%, which is pretty shocking. And this includes non-contiguous body parts, same patient going to the same practice, but having different radiologists reading it. So for example, if a patient shows up with a CT scan and then later has an MRI scan, probably a different radiologist reading that at a different station, but there are enormous synergies and efficiencies when that happens, willing to justify these fairly sharp payment reductions. Now, I don't think anyone here believes this, because it's very hard to understand how, if you're reading an MRI later in the day for a same patient that a different radiologist read earlier with a completely different modality, exactly where those synergies are. But the bottom line is that's the justification for this. And the question becomes, where did these numbers come from? Back to the dude, back to Ed Deming. Where's the data? So that's really the key question here. Without that, it's just an opinion. So here's where you see all the parts working together. The government relations team submitted a Freedom of Information Act request to CMS and said, where is your data? Now, if you know anything about that part of the world, it can take anywhere between 2 to 3 to 5 years to get data back from that. I think it took them almost 2 years to get an answer. But we don't sit still while we're waiting. The Newman Institute sponsored a couple of very key publications where we went out and collected data, looking at retrospective data, data at specific centers, and understanding exactly what do we think the synergies are in this world. And the synergies were seen to come in relatively single digits, 5, 6, 7%. Finally, the Freedom of Information Act request comes out, and what do we learn? There is no data. CMS just made the number up, and they were caught red-handed. So at that point, congressmen came together, crafted legislation, and thought, well, since there happens to be real data here, let's just knock that down to 5%, because real data wins in the policy world. And what does that mean to you as a radiologist? Well, it turns out that moving from 25 to 5%, or 20 to 5%, generated an annual savings of $2,500 a year in professional components reimbursement per radiologist, for a total of $50 million of professional component reimbursements per year. That's a pretty substantial savings. And again, why? Because we have access, because we have advocates, and because we have real data. So let me try a different component of the policymaking process. I'm going to focus on the one folks think the least about, private organizations. Let's talk about the Hawaii pre-authorization fight. What is this, you might ask? Well, several years ago, in the state of Hawaii, their Blue Cross Blue Shield carrier said, you know, we really have a lot of imaging here. I need to save some money. Let's just require pre-authorization for every advanced imaging test that's going to occur in the state. No problem, right? Plenty of waste. And why? Because they say Hawaii imaging spend is too high. So they employed an RBM and mandated pre-authorization for all physicians for advanced imaging. They previously had issued gold cards to physicians who were particularly judicious in their imaging utilization. Well, they suspended those. And then they initiated legislative action to try to mandate and codify the use of pre-authorization under the guise of saving Hawaii consumers and, of course, Medicare and Medicaid carriers through that state, really goes through Medicaid, and hopefully benefit consumers and save taxpayer dollars there. And what's the justification? Because Hawaii's utilization numbers are simply higher than the national average. But again, it goes back to the data. Can we see it? This was actually playing out over the television screens on evening news. It's a hot issue at the time. The AMA got involved, and of course, ACR's Hawaii chapter, and asked, where is your data? And their answer was, I'm sorry, we're a blue, it's proprietary. We just can't share it. Okay, well then what? Well, Hawaii's ACR chapter reached out to me at the Newman Institute and said, can you help us with this? And I said, well, that's not really what we do. We don't write bespoke studies in response because we're not chills. But let me tell you what we do. We have a website. And on that website, we have data tools. You'll find them circled in red. Either you could access them through the bar at the top or through a direct hot link on the corner. And I said, why don't you go to the Newman Almanac, where we've collected terabytes of data from public and government sources and already distilled them into more than 125 series of state and national level data designed specifically to inform the radiology policy debate. And anyone can look at this, CMS, researchers, private practitioners, and certainly the evening news. So what does that mean? Well, I pointed that to them. And literally the very next day, front page of the Honolulu Star Advertiser. Here's this graph citing the Harvey L. Newman Health Policy Institute, demonstrating pretty clearly that Hawaii is not only underneath the national average, it's one of the lowest utilizers in this country if you put the rest of the states in there. You will be absolutely shocked to discover that the Blue had to react to this. They reissued all of the gold cards. They were initially threatened with legislation, and ultimately legislation was passed in Hawaii State House and Senate for treble damages and other pecuniary damages if any patient has complications or delayed care because of their pre-authorization. The only thing saving this from being signed by the governor was a lot of pressure from the Blue with a big promise that says, okay, we'll do a lot better. We get it. Back off. We don't want this codified against us. And as such, they've backed off, and things have calmed down a bit in Hawaii. So while we're talking about the sort of data we have, and again, this is a great example where just having data helps because everyone has an opinion. But just having this data in place makes a difference. So when we talk about our website, it's great that I demonstrate you can open the door and advocacy folks can walk in with firm, real, credible research under their arms and make a difference. But I'd like to note just existing and having this data available makes an enormous difference. Our website has visitors from over 2,000 distinct networks. We've had well over 500,000 distinct visitors over the past 7-8 years of our website. And we can look using our Google Analytics at who's actually looking at our website. And it turns out we are routinely examined by CMS, Health and Human Services, MedPAC, Veterans Administration, leading academic institutions, major payers, most of the major blues, United Healthcare, Aetna, etc., and every blue chip consultancy in this country. So we know they're paying attention to what we're putting out there to help inform that policy process in a very indirect way beyond when we have direct advocacy bringing our research to the policymakers. So ultimately, it's really just a fine three-legged stool of translating research to true imaging policy. And it requires 3 equal players. It requires RADPAC. It does require the money to be the key that opens the door. And you absolutely need a committed, dedicated, well-connected government relations team to promote the research outside of that scientific arena. But at the same time, you've got to have ideas to sell. And so translation research into policy is coming up with the ideas that can be sold. And again, think about this three-legged stool. You have money, you have advocacy. You can go a little far with that, but ultimately those lawmakers have to respond to their constituents. It has to pass the sniff test. So without those ideas, and that credible idea, it's not going to go anywhere. And if you have ideas without access, well, who's reading that peer-reviewed paper? So ultimately, you have to have all 3 legs to truly translate research into policy in a way that's going to benefit the entire radiology community. So with that, I'd like to thank you. And at this time, we'll take questions.
All right. Well, thank you, Dr. Hughes. We're now going to begin answering the questions submitted during today's presentation. As a reminder, you can still submit questions through the questions pane of your attendee control panel. All right, our first question is, how are these different activities funded?
That's actually a very good question. So these activities are funded through different mechanisms, and it's actually very key that all 3 of them are well funded because, as I mentioned, it's a 3-legged stool, and without any one of these pegs, you really can't move very far in the policy process. So RADPAC is funded directly from donations from ACR members to RADPAC. Advocacy is funded largely, if I said largely, it's funded entirely out of ACR member dues. In fact, they're first in line as far as the dues dollars arrive. And when advocacy folks and government relation folks are fully funded, then we look over the rest of the dollars for performing things such as research. So the Newman Health Policy Institute is actually funded from a variety of sources. We receive a substantial share of our funding from member dues, but at the same time, we have to actually supplement that to be fully effective. And we do that by seeking external grants, which has its own problems because it's easy to find grant money to study random things. It's very hard to find grant money to study the things that we're particularly interested in, which is understanding reimbursements and evolving healthcare delivery models for radiologists. And so we pursue grants where we can find clear synergies. And then at the same time, we're really able to leverage what we can do with a very generous contribution from the ACR Foundation, which really supplements and provides us the needed resources to continue to provide the sort of data and infrastructure we need to be successful.
All right, well, thank you. Our next question is, because your research is used to support specific policy issues, how do you ensure that this is really objective research?
Okay, now it's time for the hard ones. Let me think about this for a minute. Fundamentally, and I probably should have had a slide about this inside the deck. That comes back to asking, where does our research portfolio come from? So going through this presentation, you might think that we're largely sitting around, or I'm sitting around thinking, what's the hot legislative item? When is a state chapter going to call me and provide research that's valuable? But actually, that's not our approach. The first component is we have an independent board. So we're not directly governed through the normal committees, commissions, and processes through ACR. We have an independent advisory board that we meet with several times a year that comes up with broad agendas. And at the same time, I spend an enormous amount of time really putting boots on the ground and ears to the ground, talking with members, talking with state chapters, going to significant health policy as well as radiology conferences to try to think about what the key issues are. But most importantly, while we do in fact perform research, when we see hot items like that, we also perform a lot of speculative research in terms of where we think health policy is heading. For example, several years ago, we had a crazy idea thinking that the scope of practice for nurse practitioners is going to be an issue, and it might cause problems across many different domains in the policy area. And so we wrote a paper trying to understand how are nurse practitioners and physician's assistants and other mid-level providers actually utilizing imaging separate from other kinds of providers, primary care providers, specialty providers. We published that in JAMA Internal Medicine, 2014, 2015. And, I was very proud and pointed that out to some of the folks we interact with, and their comment was, so what? I mean, that's not an issue. Fast forward the clock 2-3 years, Veterans Administration starts issuing rules talking about expanding the scope of nurse practitioner with precise language about ordering and interpreting medical imaging with no qualifiers. Fortunately for us, we had some evidence sitting in the wings that they could cite, and actually was cited in the final rule that modified that and removing the interpretation component from nurse practitioners. And so again, our credibility is based on the fact that we're not directly organized with RADPAC. We're not directly organized with government relations. We're a standalone, independent think tank. Yes, we listen, we pay attention to be effective, but ultimately we're crafting a very intentionally broad and diverse research agenda designed to address the problems of today and the future.
All right, thank you. Our next question, which one of these three activities, RADPAC, advocacy, or research, is the most important for real policy change?
Wow. I see I failed here inside this webinar. As I put on the last slide, it's a three-legged stool. You've got to have all three of them. Again, if you don't have access, who's reading this research? Doesn't matter. And unfortunately, in this country, access requires money. But if you don't have any ideas, there's nothing to sell. And it's just someone hoping that their good looks and personality from our fantastically good-looking and very gregarious GR team, by the way, that's going to be enough to win the day. But the two examples I showed demonstrated that the person with data usually wins these debates in the long run. So again, you've got to have the data. You've got to have people who can really promote that and craft the relationships to ensure that it reaches its proper place in the process. And you've simply got to have the dollars to open those doors. And so, I mean, there is no single important process. You really have to have all three with essentially equal weights. Doesn't mean they're all funded the same. Doesn't mean they all have the same size. But the importance of each one of them is vital and critical for having the sort of policy-oriented advocacy and research that radiologists need to not just, cope and manage this evolving healthcare environment, but to really find opportunities to thrive.
All right, well, that was our last question. Perfect timing. So thank you, Dr. Hughes, and thank you, everyone, for attending today's Health Policy Research 101 webinar. If you have any other questions, please contact Brandy William, the ACR Foundation's fundraising specialist, at bwilliam@acr.org. On behalf of the ACR Foundation and our presenter, thank you for joining us today and have a great rest of your day.